So today our topic is bilirubin metabolism and jaundice. What is bilirubin? Bilirubin is a yellow pigment formed from the breakdown of heme, mainly from hemoglobin. Normal level 0.3 to 1.2 milligram per dl. So two types, unconjugated and conjugated. Unconjugated bilirubin is lipid soluble bound to albumin, not excreted in urine. Conjugated is water soluble, excreted in bile and urine. Now the bilirubin metabolism. Hemoglobin, from hemoglobin, one portion is heme and another is globin. But here we are concerned about heme. From heme, biliverdin to bilirubin, then unconjugated bilirubin bound to albumin, then liver, that is called hepatic uptake. Bilirubin enters hepatocyte, conjugation, bilirubin plus glucuronic acid, conjugated bilirubin, excretion into bile, then bile intestine form urobilinogen and scargobilin. And urobilin form is secreted in urine and scargobilin form is secreted in feces. So here you can see heme, from heme to biliverdin, from biliverdin to bilirubin, then bilirubin albumin complex, then liver, hepatic uptake, then bile gut, and here it is from urobilinogen and scargobilinogen. See, it is scargobilin and urobilin. So definition of jaundice. Jaundice is yellowish discoloration of the skin, sclera, and mucous membrane due to hyperbilirubinemia and deposition of bile pigment. It is usually detectable clinically when the plasma bilirubin exceeds more than 3 mg per dl. Jaundice is not a disease, but rather a sign that can occur in many different diseases. Types of jaundice: prehepatic jaundice, intrahepatic jaundice, and posthepatic jaundice. Prehepatic jaundice arising from the blood before it entered the liver. Here serum total bilirubin 5 to 17 micromole, millimole, or 0.3 to 1 milligram per dl. Intrahepatic due to disease of liver parenchyma. And posthepatic, the result of obstruction of biliary tree outside the liver. Now the etiology. Etiology of prehepatic jaundice: increased heme liberation and defective liver metabolism. Hemolytic anemia, malaria, reduced red cell lifespan, congenital enzyme defect, iron storage disease, reduced hepatic bilirubin uptake, alcoholic liver disease, and intrahepatic obstruction of small bile duct. Example, hepatic tumors, pregnancy. Posthepatic obstruction of large bile duct. So gallstone, carcinoma of pancreas, gallbladder, bile gut, pancreatitis, grafts. Now here are some drugs that causing jaundice. Dose-dependent hepatocellular damage. You can remember the drug name only which can cause jaundice. Drugs are acetaminophen, salicylate, disulfiram, isoflurane, just few names. So now pathophysiology. Cause sickle cell crisis, blood transfusion, hemolytic drugs, hemolytic anemia, new excess hemolysis of RBC, destruction of erythrocyte, hemolytic or prehepatic. Unconjugated hyperbilirubin, jaundice. Sign and symptoms of jaundice: yellowish discoloration of the skin, mucous membrane, and sclera. Sclera is very important. So yellowish discoloration of skin and sclera is called jaundice. If only skin, it might not be jaundice. Light colored stool, dark colored urine, itching of the skin, nausea, vomiting, abdominal pain, fever, weakness, loss of appetite, headache, confusion, swelling of legs and abdomen. Now, how will you differentiate between pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice? So, total bilirubin, pre-hepatic, normal or increase. In hepatic and post-hepatic jaundice, total bilirubin will highly increased. Conjugated bilirubin, normal. Here, increased. Unconjugated bilirubin, here, increase. And hepatic jaundice, increase, post-hepatic, normal. Urobilinogen, normal or increase in case of pre-hepatic jaundice. Hepatic jaundice, increased. Post-hepatic, decrease. Urine color, normal. Here, urine color, dark, due to urobilinogen plus conjugated bilirubin. Stool color, normal. Hepatic and post-hepatic, normal or pale, pale. Now the enzymes. Enzymes will normal, but here enzymes will increase. Now the inborn errors of bilirubin metabolism.
লাস্ট বেঞ্চের আগের বেঞ্চ কথা হচ্ছে খুব ভালো না লাগলে ক্লাস থেকে চলে যেতে পারো কেউ রিকোয়েস্ট করেনি তোমাদেরকে কিন্তু ক্লাস ডিস্টার্ব করবে না
Now the inborn errors of bilirubin metabolism. Genetic mutations can result in impaired uptake, conjugation, or secretion of bilirubin. So, Crigler-Najjar syndrome type 1, caused by severe UGT1A1 deficiency and is fatal around birth. In Crigler-Najjar type 2 and Gilbert syndrome, there is some UGT1A1 activity leading to a milder phenotype. So, Crigler-Najjar 1, the enzyme is totally absent. And Crigler-Najjar type 2 and Gilbert, enzyme is present but in milder phenotype. In contrast, Dubin-Johnson syndrome and Rotas syndrome leads to conjugated hyperbilirubinemia. So, unconjugated form is found in Crigler-Najjar and Gilbert syndrome, and conjugated form found in Dubin-Johnson and Rotas syndrome. Both are autosomal recessive disorder and is clinically innocuous. Dubin-Johnson syndrome is caused by mutation in the MRP2 gene, multi-drug resistant protein 2, MRP2 gene, which is required for transport of non-bile salt organic acids at the canalicular membranes. Deposition of brown-black melanin-like pigment in the hepatocyte is a striking feature in this disease and can lead to blackening of the liver. So, unconjugated hyperbilirubinemia, problem before liver conjugation, that is pre-hepatic. Gilbert syndrome, defect, mild decrease of UDP glucuronide transferase enzyme, inheritance, autosomal recessive. Features, mild intermittent jaundice, no hemolysis, serum bilirubin will less than 3 mg per dl. Prognosis benign, no treatment needed. Crigler-Najjar syndrome type, defect, complete absence of UDP glucuronide transferase, autosomal recessive, serum bilirubin high, prognosis fatal without liver transplant. Type 2, partial deficiency of enzyme, features less severe than type 1 because the enzyme is present here. Response to phenobarbital, prognosis moderate, manageable. Then, conjugated hyperbilirubinemia, problem after conjugation, that is Dubin-Johnson syndrome. Defect, impaired transport of conjugated bilirubin into bile, cause MRP2 transporter mutation, features mild jaundice, black color liver, pigment deposition, prognosis benign. So in Dubin-Johnson, the color of the liver is black. Then Rotas syndrome. defect, impaired hepatic storage or reuptake features, mild jaundice, no liver pigmentation, prognosis benign. So, Gilbert, Krigler-Yassar and Dubin-Johnson-Rotter. So, how will you differentiate? In Gilbert, unconjugated form is found, decrease engine, severity mild. In Krigler-Yassar one, unconjugated, totally absent of enzyme. Severity severe. Krigler-Yassar 2, unconjugated, partial deficiency, moderate. Dubin-Johnson, conjugated, transport defect, mild. Rotor, conjugated, storage defect, severity mild. Now the neurical jaundice. So definition, yellow discoloration of skin or sclera in a newborn due to elevated serum bilirubin, that is more than 5 mg per dl. In physiologic jaundice of newborn, levels of UGT1A1, the enzyme that is responsible for bilirubin glucuronidation, are low at birth and do not reach adult level until 3 to 4 months of age. Hence, transient and mild unconjugated hyperbilirubinemia is nearly universal in the first grade. So, neonatal jaundice is quite common. Breastfeeding may exacerbate unconjugated hyperbilirubinemia, possibly because of presence of bilirubin deconjugating enzymes in breast milk. In most infants, physiotherapy with blue light, which convert bilirubin to a soluble isomer that is readily excreted in the urine, is sufficient to keep the levels of unconjugated bilirubin within a safe range until the hepatic machinery for conjugation matures sufficiently. Why it happens? Pathophysiology. Three main reasons. Increased RBC breakdown. Newborns have more RBC plus shorter lifespan. RBC is more but shorter lifespan. Second is immature liver enzymes and decreased excretion. Poor feeding, less stool, bilirubin reabsorbed. So causes of neonatal jaundice: unconjugated hyperbilirubinemia, physiologic and prematurity jaundice, hemolytic disease of the newborn, and carnivorous, congenital hemolytic disorders, perinatal complications, Gilbert syndrome, Crigler-Najjar syndrome, type 1 and type 2. Then conjugated hyperbilirubinemia, hereditary Dubin-Johnson syndrome, and Rotor syndrome. Infections, hepatitis B, hepatitis C, or non-A, non-B hepatitis, and metabolic, galactosemia, alpha-1 antitrypsin deficiency, like this. Types of neonatal jaundice: physiological jaundice and pathological jaundice. So, number one is physiological jaundice. Onset of physiological jaundice after 24 hours. After 24 hours is physiological jaundice. Less than 24 hours is pathological jaundice. Peak day 3 to 5 in case of term baby, bilirubin less than 15 mg per dl, baby condition otherwise normal. Then pathological jaundice appears within first 24 hours. If the jaundice appears within 24 hours, then it is no more physiological, it is pathological. Bilirubin level more than 15 mg per dl, rise more than 5 mg per dl per day. Persist more than 14 days. Causes: blood group incompatibility, RH or ABO, hemolysis, eosinophilic deficiency, infections, genetic disorders. Risk is cardiac tears. Cardiac tears means bilirubin deposition in brain. That is permanent damage. That is irreversible damage. If cardiac tears happens, it is irreversible damage. Special types: breastfeeding jaundice and breast milk jaundice. These are different. Breastfeeding jaundice is due to poor intake, dehydration. Early onset first week. Breast milk jaundice due to substances in milk inhibiting conjugation appear after 1 week. Investigations, serum bilirubin, total direct indirect blood group, Coombs test, hemoglobin, and reticulocyte count. Management, mainly phototherapy. Blue light converts bilirubin to water-soluble form, most common treatment. Then essence transfusion for severe cases, removes bilirubin plus antibodies, feeding, ensure proper breastfeeding. Now, the difference, onset is more than physiological jaundice and pathological jaundice. Physiological jaundice more than 24 hours, pathological jaundice less than 24 hours. At level, mild increase, highly increase. Risk in physiological jaundice, no risk. But in pathological jaundice, there is always a risk of cardiac arrest. Treatment, no treatment need in physiological jaundice, but treatment is needed in pathological jaundice, that is phototherapy or essence transfusion. Now, the management. Jaundice, history plus examination. Young patient, management is different. Older is slightly different. Young patient, we have to do viral markers. If viral marker negative, then ultrasound, no CVD dilatation, then recheck drug history or antibody. If viral marker positive, then it is hepatitis. Older patient, ultrasound plus liver biochemistry and viral markers. Ultrasound normal, viral marker positive, hepatitis. Viral marker negative, and inflammation tumor, metastasis, then we have to do biopsy. And CVD dilatation, if it is due to gallstone, then we have to operate the patient. CVD dilatation, other biliary obstruction, then we have to do MRCP, that is magnetic resonance cholangiopancreatography, MRCP procedure.